Well, so far, we've talked a little bit about just the basic approach to the exam, and we've gone through some cases. We've looked at a quick demonstration of a normal exam. Next, we're going to talk through just the different structures that we'll look at, and what the normal and abnormal findings are going to look like. The first of that is going to be the anterior chest. You don't have to start here. You can start wherever you want. This is my typical practice, but I even alter this depending on the clinical scenario or my practice setting. So the main question that we're trying to answer is there pleural sliding, yes or no? And most of the questions we're going to do in the FAST exam are yes or no questions. So this is how the patient's going to be supine typically. We place the probe in like the third or fourth intercostal space, not up at their clavicle. We want to be at the kind of the part of the chest that's closest to the ceiling. That's how I describe it. We want to be in roughly the midclavicular line. The indicator is towards the patient's clavicle. We want to decrease the depth so that the pleural line is in the center of our screen. Answering the question of sliding, yes or no. Let's go ahead and take a look. Now, here's what that may look like. Our depth, I cropped the markers off of here, but the depth in these images is, at about 4 or 6 centimeters, depends on how thick your patient is. But we should see ribs that maybe cause some shadows. This is all chest wall, which hopefully is pretty stationary. And then here we see the pleural line, and it's sliding. It goes underneath the ribs, slides back and forth. We see these little comet tail artifacts, which are just normal findings with the ribs. Over here, another example, we see a little rib shadow. We see a little rib shadow. And we see the pleural line sliding back and forth. We see this pleural line's got a little bit of roughness, has a couple of B-lines. We'll talk about what that might mean in trauma. Now, this is how it would look with a linear probe. I'd like to show you how it looks with the pretty probe before I show you how it looks with the ugly probe. So when we're using a curvilinear or maybe a phased array probe, the pictures aren't going to be as pretty. The biggest thing with these is decrease the depth so that the pleural line is roughly in the center of your screen. Here, we probably could have decreased the depth even a little bit more, but we can still see we have to hold the probe still. When we're looking at moving objects like sliding or moving pleura or the moving heart, once we find our spot, we want to hold still so that we can observe the movement. So here, if you focus your eyes, you can see the pleural sliding. Sometimes you may need to ask the patient to take a breath, but most of the time you don't. Again, decrease the depth. Sometimes it helps to decrease the gain. So decreasing the gain can help you pick this up a little bit more easily if it's kind of difficult. But we see pleural sliding here. We see pleural sliding on this side. There's rib on the edge with shadows and then pleural sliding. Again, this decent example, maybe should have decreased the depth a little bit more. And again, turning down the gain sometimes can help as well. But that's what pleural sliding looks like. If you see that, then there's probably at least no large pneumothorax. Could there be a small little apical pneumothorax? Yeah, there could be, but you probably don't need to act on that immediately in the resus bay. Now we'll take a look and try to recognize the abnormal findings over here. So hopefully you can see which one is different and which one's abnormal. So here we see pleural sliding. We're holding nice and still. The chest wall moves a little bit while the patient breathes, but we see nice little movement across here, those little comet tail artifacts. Over here, we see a rib. There's probably a rib right off the edge here, a little shadow. The chest is moving because the patient's breathing, but we don't see any pleural sliding. No sliding here. So this means that patient probably has a pneumothorax. Now, if you're not sure, ask them to take a deeper breath or try to get that pleura to move a little bit. If they're splinting a lot because they have pain and rib fractures, then that may limit sliding. There's a few other caveats we'll talk about. But for the most part, if you don't see sliding, they've probably got a pneumothorax. And if they're sick, you should put a chest tube in. So there you go, normal versus pneumothorax. And that's with the linear probe. Now let's see how it looks with the curvilinear, maybe even the phased array probe. This is where you have to hold still. You've got to decrease the depth. Maybe you turn the gain down a little bit. Here, hopefully pretty obvious. Lung sliding. Versus this side, the ribs are here, shadows. We don't see any sliding here. So this patient has a pneumothorax. And if you're in doubt or questioning yourself, you're trying to decide, all right, I'm going to put a chest tube in or not, switch to your linear probe and just double check yourself if you're not sure, if you have that available to you. So again, normal versus pneumothorax. And there's just one additional finding. This won't come up that often, but sometimes you may see the lung point. So that's the transition of where the lung is up versus seeing where it's down. So here you can see this is the pleural line here, and we see that lung kind of popping up and down as they breathe. That's the transition point of where the lung is opposed to the parietal pleura versus where it's down. So this is This is one of those findings that's almost 100% specific for pneumothorax. If you see this, if you see a true lung point, they have pneumothorax. There's pretty much no doubt about it. Over here, same thing. We see no sliding here. We see some sliding kind of moving up and down as they breathe. That's the transition point where lung is up versus where lung is down. This is, like I said, nearly 100% specific for pneumothorax. If you see this, they have a pneumothorax. I'll just point out here as well, we see some B lines in the part of this lung. That may be from atelectasis, where the lung is collapsed, or it could be from pulmonary contusion as well. We'll talk about that more later. So again, just like we talked about, and talking about the evidence behind this a little bit, the supine chest x-ray in the trauma patient, especially when they've got the backboard and things behind them, it's really not that sensitive for pneumothorax. Ultrasound is far superior in sensitivity than that AP supine chest film, 98 versus 75%. And in multiple studies now, this has been duplicated. Ultrasound for pneumothorax decreases the time it takes to make the diagnosis and decreases the time to treating the pneumothorax. So this should be a standard thing. And I'm not saying don't do the chest x-ray. The chest x-ray is nice to see a whole bunch of ribs at once. It's nice to look at the mediastinum. So I'm not saying don't do the chest x-ray, but I'm saying that I think the ultrasound is probably a higher priority immediately and is definitely more accurate when it comes to identifying pneumothorax. The thing that comes up with pneumothorax frequently is, well, ultrasound doesn't tell me how big the pneumothorax is. How do I know if I need to intervene on it or not? So I put together this little, again, this is not a prospectively validated algorithm. This is Minardi's treatment algorithm for pneumothorax and trauma with ultrasound, and how you use this to take care of the patient. What you have to remember is we're all providers, we're all physicians, we have brains, we have to use our brains in addition to the information that ultrasound gives us. So the easiest part of this is you use ultrasound, you look and see if there's pneumothorax. If there's no pneumothorax, please don't place a chest tube. Pretty straightforward, pretty easy. Consider other workup. Maybe you're worried about a small pneumo or an something like that, whatever. If you don't see a pneumothorax immediately with ultrasound, don't place a chest tube. If you do see a pneumothorax, then you have to be a doctor, right? You've got to decide, are they sick? Are they in shock? Or do they have major respiratory findings? They're hypoxic, they are clinically short of breath, tachypnic. So if they're in shock or they've got significant respiratory findings, then consider putting a chest tube in. That's pretty straightforward. Pneumothorax, sick patient, chest tube. Pneumothorax, not in shock, respiratory-wise look okay, then wait, do other workup. Do the upright chest film. You could do a more extensive lung ultrasound if you wanted. Maybe do a CT scan. But if the pneumothorax is not causing them to be clinically unwell, then you can wait and do other workup. That's my answer to what do I do with that information in the patient if I don't know how big the pneumothorax is. The answer is incorporate the clinical information and decide what to do. Sick, pneumothorax, chest tube. Pneumothorax, not sick, wait. Other workup. And that brings us back to one of the cases we looked at the beginning, which was the 72-year-old female who came in after a motor vehicle crash. She's hypotensive and she has diminished left breath sounds. So the immediate thought might be she's got diminished breath sounds and she's hypotensive, probably has tension pneumothorax. We got to put in a chest tube. Here's her ultrasound. So on both sides, we can see there is sliding. So this would suggest there is no pneumothorax despite being short of breath, hypotensive, and diminished breath sounds. And the reason is, if we go back, her other imaging would suggest she had a diaphragmatic rupture from trauma, and that's why she was short of breath with diminished breath sounds. So doing the ultrasound at the bedside gave us the correct clinical information that helped us decide to withhold the chest tube, which probably would have gone into her descending colon and would have been much worse for the patient. So if you see sliding, they don't have a significant pneumothorax, you can withhold the chest tube at all or until other workup changes your decision making. So that's the chest and how you look for pneumothorax, the anterior chest. We'll get to the dependent chest here in a little bit. The next move I usually do, or the next place I usually go, is to look at the heart for hemopericardium. Now, hemopericardium is not that common in blunt trauma, but a very significant concern in penetrating trauma, and we'll talk about that. And our questions are pretty straightforward. Is the heart beating? Yes or no? And is there hemopericardium? Yes or no? Now, as you get more advanced, you may be able to pick up signs of blunt myocardial injury, which may be causing cardiogenic shock. That's beyond the scope of what we're going to talk about today. And if you want more information on that, if you haven't already, you should check out our web course on heart and lung ultrasound in identifying cardiogenic shock. So for this, most of the time, we're going to be using the subxiphoid cardiac window or the subcostal window. Now notice that we're not going to switch settings around. We're just going to leave the machine in the abdominal or the fast exam setting. So our indicator will be to the left of the screen, but we'll orient such that we can see the heart in its normal orientation that we're used to seeing when we're doing cardiac ultrasound or bedside echo. So just refreshers, livers here, the ventricle closest to us is the right ventricle. The apex of the heart's here, base is back here. This is right atrium, right ventricle, left atrium, left ventricle. We see the bright white pericardium adherent to the heart wrapping all the way around. And this is our view right here. Now I will point out that sometimes our patients can be a little more difficult to image. Sometimes that subcostal or subxiphoid view is limited and not helpful in some of our patients, so we can use the rescue view or the peristernal long axis view, where we just place the probe up in the chest in roughly the third or fourth intercostal space left of the sternum. If we're still in the fast or abdominal setting, which we probably are because we're doing a fast exam, then ideally we should direct the indicator towards the patient's left armpit or left kidney to give us a peristernal long axis view with the curvilinear probe. And this is what it should roughly look like. We'll switch the apex to this side, base of the heart's here, right ventricle still closest. Here's the left ventricle, left atrium, mitral valve. And again, we're not trying to get a lot of detail in the trauma setting. We're just trying to figure out, is the heart beating and is there pericardial effusion? So we'll pay lots of attention to this pericardial space here. This view is necessary in a significant number of our trauma patients who are obese or have abdominal pain, and we can't obtain a satisfactory subcostal view. Now we'll just look at a few examples of the findings that we're looking for. And remember, it's yes, no. Is there blood around the heart? Here's just a still image showing fluid around the heart. Usually the fluid's going to be black, but not always, because maybe it's starting to clot and it can become gray. Keep that in mind. It should be circumferential, and as the heart's beating, the shape should change a lot throughout the cardiac cycle. So let's take a look at a moving picture. So here we can see fluid. It goes all the way around. We see some of it posteriorly, not as much, but we definitely see it there. So that's a clue. It's circumferential. And here we can even see a little bit of compression on the right ventricle. The right ventricle still fills pretty well, but there's a little denting here. There's a little denting in that right atrium, probably during systole. So this is a pericardial effusion. Now, in the trauma patient, we may need to make the assumption that this is blood, but don't forget, there are patients walking around with small chronic pericardial effusions, and we may find those in trauma. So with all of these things, there may be chronic ascites, there may be chronic pleural effusion, there may be chronic pericardial effusions. We have to incorporate the entire clinical scenario. Here are a few others, and this is what I was talking about when I said blood does not always look black. So this is similar to what we saw earlier. This gray stuff, we see black, kind of fresh blood wrapping all around. And notice the changing shape throughout the cardiac cycle. But all this gray stuff is clotted blood. So we have to recognize that blood is sometimes gray. And this happens. I've seen trauma patients who are in the emergency department within 15 minutes, and you find clot in their abdomen or their chest. And you see other patients where the blood looks black for hours. I can't tell you that it follows the linear clotting trajectory that we were all taught in medical school. I can just tell you that sometimes blood looks gray. This example as well, we can see some of the black fluid circumferential around the heart, but some of this stuff that's kind of gray is also blood that's starting to clot. So keep in mind that blood, as it starts to clot, may become gray, and we have to be able to identify that in our trauma patients. Some examples there. We'll see that in the abdomen as well. Now, I just want to make a quick note on the penetrating trauma patients. In my practice setting, I don't see this as much. However, we do see it, and I want to point out how in penetrating trauma, a lot of times the first thing we want to know is, what's the heart look like? Is there blood around the heart or not? That's going to immediately impact our intervention plan and how we're going to manage these patients. If we have surgical backup available, the surgical approach may be worked around where the blood is. Maybe that patient gets a midline sternotomy instead of a lateral thoracotomy when they go to the operating room. Or if this patient arrests in front of us, we know what our approach needs to be right away. So this can be very important in penetrating trauma planning. And in some studies, what's been demonstrated is if there's penetrating trauma with no pericardial effusion and no cardiac activity on arrival, the likelihood of survival is incredibly low. Now, I'm not going to say you should decide to begin resuscitation or not based on that, but that's something that's been suggested in some of the trauma literature. Certainly, if there's pericardial tamponade from trauma and we can address that, then we increase our patient's odds of survival, again, depending on our scenario and our setting and what resources we have. So just think it's important to recognize the role for fast exam and ultrasound in trauma, even in penetrating trauma. Now, I kind of alluded to this already. Just remember, people can have chronic effusions. There are people walking around with fluid in their chest, fluid around their heart, fluid in their abdomen that's been there for other reasons for a long time. And as always, we need to be clinicians and make clinical decisions based on not just the ultrasound, but all of the information in front of us. Okay, so we talked about the anterior chest looking for pneumothorax. We talked about the heart. Next, we're going to move on to dependent parts of the chest and then examining the abdomen and what normal findings are going to look like and some of the abnormal findings that we may look for. So our main questions are, is there fluid in the chest or is there fluid in the abdomen? Yes or no questions should be relatively easily answerable with ultrasound. Now, we talked about when we look at the heart and we look at chest sliding, we're looking at moving structures. We kind of find our spot and we hold our probe nice and still so we can observe that movement. However, once we move to the dependent parts of the chest and the abdomen, we want to fan the transducer from ceiling to floor, working our way from the chest down to the abdomen and examine these areas completely. We don't want to take single pictures. We want to take multi-slice imaging examinations. We start above the diaphragm and work our way down into the paracolic gutters. So let's take a look at what that might look like. I usually go from the heart to the right side. And first we want to identify the diaphragm for two reasons. One, we're looking to see is there blood or fluid in the chest above the diaphragm, but we're also looking for fluid below the diaphragm in the subdiaphragmatic space. That's one of the potential spaces where hemoperitoneum may accumulate. So just an example, find that bright white diaphragm, get the transducer towards the bed, get it between the angles of the ribs so you can identify this. There's a few other findings to note. The spine sign with shadows. Here we see spine, and here we see kind of nothing in the chest. If you really want to nerd out on physics, part of what you see here is a mirror image artifact from the bright white diaphragm. If you want more on that, follow me on Twitter or send me an email and we can talk physics. And here are examples of what fluid, or if it's fresh blood, may look like in the chest. You're going to see black stuff. Maybe it could turn a little bit gray if it's blood, or you might see kind of floating particles in there if it's blood. But take note, it's above the diaphragm. Look for the spine sign, which you can see floating in and out here. Similar example here, you find the diaphragm, that's your big landmark, and looking for blood above the diaphragm. And if the patient is unstable, this may help you decide to place a chest tube to drain the blood, to help their breathing, and monitor their continuous bleeding, whether it's transient bleeding or whether it's continuous bleeding, which may help you decide on surgical management. Gets back to one of the cases we had. Here's our 38-year-old male after an ATV crash. Patient's short of breath and hypoxic with diminished breath sounds. Their anterior chest, we saw sliding, but we see here's the reason for the diminished breath sounds. This is blood in the chest, and we may decide that we want to go ahead and place a chest tube. Again, the clinical scenario is going to help us decide, like, how short of breath are they? How hypoxic are they? We incorporate this into the entire clinical scenario. So we start with the transducer looking above the diaphragm, and we just work our way down the abdomen, fanning the transducer from ceiling to floor to look next for intra-abdominal fluid. And just a reminder of where some of the potential spaces in the abdomen are. This is what we're looking for. The spaces are subdiaphragmatic, Morrison's pouch or the hepatorenal recess. Then on the left side, we've got the perisplenic area, paracolic gutters, and then we'll talk about the pelvis. Don't forget the paracolic gutters. Your exam is not complete if you haven't examined those areas. So just a little outline to show you. So subdiaphragmatic space here. So it's important to not only find these landmarks and identify them on all of your exams, but key your eyes into these spaces because this is where blood and fluid may accumulate. Then on the right side, we've got Morrison's pouch. On the left side, it's more likely to be in the subdiaphragmatic area. So the left side, I always like to emphasize and key in with learners on identifying the diaphragm. I like to identify it on both sides, but even more detail on the left. There's not as much potential space between the left kidney and the spleen. So this subdiaphragmatic area is ever more important. And then as we're talking about the right side, the right upper quadrant, we definitely want to identify Morrison's pouch because that's a common area of fluid accumulation. But we will want to examine the abdomen all the way down past that liver tip and past the kidney into the paracolic gutters to look for fluid. One of the first places, some of the literature has shown that the first place fluid is found in the abdomen from trauma is at the tip of the liver and the right paracolic gutter. So your exam's not complete until you've included those areas. And again, we're examining. We're fanning from ceiling to floor to examine all of these areas completely. So here's kind of the stereotypical image of fluid in Morrison's pouch. We can see it all around the liver, down here, past the liver tip in the paracolic gutter. Here's a little more subtle. So as we get more experience, hopefully we can pick up these subtle findings. So this is just a little sliver of fluid in Morrison's pouch. We want to be able to identify that. We work our way down. Usually we get past the kidney, fan the transducer, fan the ultrasound beam towards the ceiling to identify the paracolic gutters. The landmarks are going to be these rolling bowel signature patterns. So this is the outline of the ascending colon. And when it's normal, there's not really much to see. You can see it here as well. That little outline of the bright white is the air in the colon. So we're roughly in the mid-axillary line. We come down inferior to the kidney and fan the transducer anterior and posterior to identify these landmarks. So there's the bright white outline of what the intestine looks like. That lets us know we're in the right space and we're looking for the right things. What we see deep, the intestinal air, remember air scatters the ultrasound, so we just see a lot of blurring out and dirty shadows. We can't really see much of anything. So that's what paracolic gutters look like when they're normal. When it's abnormal, it will kind of look like fluid is pushing down on the bowel. So there's the lower tip of the kidney. Here's the paracolic gutter and the intestinal air. This is the fluid that's displacing some of that colon. Same thing over here. We see that fluid displacing the colon in the paracolic gutter. That helps us find bleeding within the abdomen. So on the left side, we do pretty much the same thing we do on the right. The only difference is we have to start with the transducer a little more towards the head and a little more posterior. A lot of times I'm almost up in the patient's axilla when I start the left side of the exam, and my hand is down on the bed. That's how posterior we need to be. Your hand holding the transducer needs to be touching the bed. The good thing is that the structures and landmarks look pretty similar. So the diaphragm is one of our big landmarks here. We want to look above the diaphragm for fluid in the chest. We see the solid organ of the spleen. Again, we see that here. The bright white diaphragm, solid organ is the spleen. We can see spine shadows, kidney here. Remember, fluid is going to accumulate on the left side in this subdiaphragmatic space and then paracolic gutter. Fluid in the chest on the left looks about the same as fluid in the chest on the right. So we'll take a look at that. We look for it. Here's what it should look like. Then we just work our way down the abdomen, again, fanning the transducer from ceiling to floor to examine these areas completely. And we're looking for fluid in those potential spaces. And I also it's important to point out that the spleen is a pretty small structure. So using your eyeballs, it should be about the same size as the kidney. It definitely shouldn't be bigger than the kidney. It should be nice and homogeneous, all pretty much the same texture. Should have nice crisp borders and good margins. You can get clues about splenic injury or not. Again, you're not going to rule it in or out, but recognizing abnormalities of the spleen. Remember, the spleen is the most commonly injured solid organ in blunt trauma. So we can, if we know what the normal spleen looks like, we can pick up some of those injuries and find other subtle things. And we'll look at some examples of that. Here's what things are going to look like when there's fluid on the left side. So again, attention to that subdiaphragmatic space, because that's the potential space on the left. So here we see fluid between the diaphragm and the spleen. Again, here we see fluid in the subdiaphragmatic space and up around here heading to the paracolic gutter. But notice we don't see it separating. It doesn't separate the kidney from the spleen because there's the splenorenal ligament here. This is not really much in the way of potential space. So around the spleen, under the diaphragm, and then down towards the paracolic gutter. That's where it goes on the left. And on the left side, paracolic gutters look the same as they do on the right, so I won't beat those to death again. And then fluid in the paracolic gutters is going to look similar to how it looks on the right. So again, won't beat that to death. We're just working our way down below the kidney, looking into the paracolic gutter, looking for the bright white bowel outline as our landmarks, and looking for fluid in these spaces. So lastly, we move to the pelvis, and most of the time we just need to do a transverse view right above the pubic symphysis. So that's one of the keys, is that these landmarks are always lower than you think they are. So palpate the pubic symphysis and place your probe just superior to that. That's where you want to be. That's where the bladder is. That's where the pelvic organs are. Normally, if there's anything in the bladder, then it's going to be this black hexagonal shape just above the pubic symphysis. If we do sagittal views like we have here, and it's a female, we may see the uterus indenting the bladder. And the uterus is going to be an important landmark in females because it's going to help us look for the right places where fluid is going to accumulate. So here's those areas. Again, in females, I think it's important to identify the uterus because fluid in the pelvis usually accumulates first behind the uterus, not behind the bladder. The pouch of Douglas or the rectouterine pouch is the first place of fluid accumulation in the pelvis in the female. So identify the uterus as well as the bladder. That's one of your landmarks in the female patient. We'll take the highlight off there so that hopefully you can recognize that trigonal muscular organ that is the uterus. Look behind there to see if there's any fluid accumulation. And here's what fluid may look like. So here, this is the uterus in the female patient. We see fluid all behind that. Here, this looks like maybe this is a sagittal view as well. So it looks superior to the bladder, but we see fluid where it doesn't belong. Again, the classic example is fluid accumulating behind the bladder, and it should layer out. So we see some of that here. Although depending on how much fluid is in the pelvis, it may look like it's surrounding the bladder, depending on how you slice through. So don't lock yourself into only seeing it behind the bladder. It may be all around or even superior, depending on how you're slicing through. But this is the kind of classic textbook area where you look for fluid in the pelvis. Remember, in the female patient, find the uterus and look posterior to it for fluid. I think I've beat that to death already. So there you go, fluid behind the uterus. The uterus is the other landmark to look for in the female patient. And that just brings us back to that third case we had of the intoxicated female who had fallen. Pretty good looking vital signs, but intoxicated, so history and exam not super reliable. You first look at the bladder, looks pretty okay. You don't really see much, but as you fan up and down and identify the uterus, which is right here, not the best, clearest picture of it, we see lots of fluid accumulated in the peritoneal space, which clued us into this patient's actual intestinal injury, which was causing bleeding and fluid to leak inside the peritoneal space. All right, so that's all of the anatomy that we're going to look for. We looked at some normal looking structures and landmarks. Very important to find all the landmarks that we care about. Now we're just going to look at some other caveats or things to be on lookout for. One of the things is, here's a case on the left side where we see the kidney. Kidney is pretty small. This spleen looks very large, and it also looks heterogeneous. It's not all the same texture. The borders, we kind of lose the integrity of the borders here. So this is important to recognize in the trauma patient. Most of this is blood and clot that's taken the place of the spleen that's been just shattered. So recognizing this, even if you don't see a lot of free fluid, although you probably see some free fluid as well in the paracolic gutter, is important to recognize because clot sometimes looks gray. So a lot of this is spleen that's bleeding and clotted. And big clues are it's bigger than the kidney, so it's bigger than it should be, and it's heterogeneous and lots of different colors and textures within it are clues that that's a bleeding spleen with clot around it. Here's another example of a patient. We're looking somewhere in the pelvis, and it might be easy to think, oh, look, that's the bladder, and it looks funny. Most of this gray stuff here is clotting blood. There's also some kind of liquid black blood we see around here. But if we don't recognize this gray stuff, we will either underestimate or not recognize at all that this is blood in the pelvis. Like we said, and we talked about it in the heart, it's also applicable in the chest and in the abdomen. Clot can be gray, and you may see different shades of gray depending on the stage of clotting that is happening. And at least in what I've seen clinically, does not necessarily correlate with the timing from injury like we would expect. And that brings us back to our first case where the patient had some abdominal pain but normal looking vital signs. Now, if we interrogate these images really finely, we probably see a little bit of irregularities here. Subtle, may be hard to call with just these images here. There's probably a little stripe of fluid, but subtle, may be hard to see. But if we complete our exam and move to the paracolic gutters, then the injury becomes much more obvious, where we see lots of blood and fluid in these paracolic spaces. Is all peritoneal blood. Here it is, displacing the intestinal air. This is intra-abdominal bleeding, peritoneal blood in the paracolic gutters. Sometimes the first place fluid is going to accumulate, so you definitely need to include these for a complete examination of the abdomen and trauma. It only takes an extra 2 seconds. Okay, so you can do this quickly. If you do it all as kind of one continuous exam from above the diaphragm down the paracolic gutter, fanning through as you go, this takes 10 seconds on each side. And just to take a look at our next case, this was the second case we talked about. This is a 36-year-old who fell from a ladder, has some chest pain, but good-looking vital signs. Again, if you interrogate this image very carefully, there's probably some abnormality and a little bit of fluid around the spleen here. So you might have detected that. Hopefully you did. Hopefully with a little practice you would have seen that. Maybe if you look in the paracolic gutter, you see a little bit more fluid. And then one of the other points of this case was, this is a 36-year-old, looks pretty good from a vital sign perspective, has a little bit of left chest pain, but they don't look that bad clinically. Maybe you're thinking, we just need x-rays to look at their chest. They didn't fall that far. Or you're thinking, they can wait while these other patients go get CAT scans or whatever they need. But instead, if you recognize even these subtle findings of fluid and some abnormalities in their abdomen, okay, this patient needs the nurse to be with them. They need that second IV. They need the blood to be with them in the room or as they go to CAT scan. They need to get CAT scan ahead of the other patients with the minor injuries or whatever. This information helps you make decisions that help you manage the workflow, manage the patients, and manage your entire department. I hope some of those cases help demonstrate some of the subtle and not so subtle findings that you may see in trauma, and then a little bit about how they can influence your decision making, even when you can get a CAT scan in 15 minutes, even when you don't have surgery immediately available. No matter what your resource setting, having this information within 2 or 3 minutes at the bedside adds value to your patient's care.